A new publication explores a commonly asked question regarding chiropractic care. Can manipulation be used to prevent neck pain if routine maintenance visits are incorporated in the management plan? The title of this publication is A Randomized Controlled Trial of Preventive Spinal Manipulation with and Without a Home Exercise Program for Patients with Chronic Neck Pain. It was published in 2011 in BMC Musculoskeletal Disorders. So, how common is chronic nonspecific neck pain? The annual prevalence is estimated to be between 30 to 50%. 50 to 85% of patients complain of persistence or reoccurrence 1 to 5 years after the initial onset. Neck pain is commonly seen in chiropractic offices, estimated at 25% of all patients. It's important to note that 90% of surveyed chiropractors believe that preventive care is helpful for their patients. Yet this perception is difficult to measure with all of the confounding variables that occur in people's lives. It is important to test this assumption in a real clinic setting, but with some comparisons to other groups. We clearly have a large number of individuals in need of preventive care, and a large percentage of our profession that believe we can help with their problem. So let's take a look at how the researchers in this study approached this question. So what are the researchers examining? Well, actually several things. Can manipulation be used to prevent neck pain if routine maintenance visits are scheduled? And also, is this augmented by adding home exercise? And finally, how do both groups do compared to a control group who do not receive regular spinal manipulation? This final group compares these interventions to the natural history of patients with chronic neck pain. Here we can see the inclusion and exclusion criteria. Starting with the exclusion criteria, note that this was a study for non-specific neck pain, so any obvious cause such as a motor vehicle accident, arthritis, infectious, metabolic, cardiovascular, endocrine, or potential neurologic cause excluded the patient. Also, pregnancy or neck surgery excluded the patient, and of course, any perceived signs of vertebral artery dissection. The inclusion criteria were standard with an age range of 18 to 60 and pain that lasted 3 months or longer. The patient could not be under other care such as physical therapy, chiropractic, or rehabilitation. They needed to sign an informed consent and agree to follow the treatment protocol. It's important to note here that patients were discouraged from seeking adjunctive or alternative care during the research period, but were not prevented from doing so. Any deviation was supposed to be noted in a diary that each patient kept. This also included any use of co-interventions in the form of ice or other approaches used to decrease pain. There were 2 phases of treatment. This included a symptomatic treatment phase and a preventive phase. In the symptomatic treatment phase, everyone was treated. Treatment visits were standardized to last 10 to 15 minutes. There were between 10 and 15 treatments over a 5 to 6 week period. At each visit, a maximum of 4 spinal manipulations to the cervical and upper thoracic areas was allowed using a high-velocity short-amplitude adjustment. Myofascial soft tissue therapy, such as trigger point therapy, was allowed, but kept to a minimum. The preventive phase was designed to extend over a 10-month period. The patients were randomized into 3 groups: a manipulation group, a manipulation combined with home exercise group, and an attention control group. For all 3 groups, visits with the chiropractor consisted of filling out a standardized short health history, a visual analog scale, standardized passive palpation was performed, and the distribution of diaries to patients was accomplished. It's important to note that no advice was given to the patient. Now let's see how each of these groups was managed differently. For Group 1, the manipulation-only group, a maximum of 4 spinal manipulations to the cervical and upper thoracic areas were allowed at each treatment. There was 1 treatment per month that lasted 10 to 15 minutes. For Group 2, the manipulation plus home exercise group, the treatment max and frequency were the same. The home exercise program was supposed to be performed at least 3 times a week. These home sessions began with general range of motion exercises for warm-up and cool-down. Then 4 stretching and mobilization exercises and 4 strengthening exercises were performed. Strengthening focused on flexion extension, lateral flexion, and rotation of the cervical spine. Exercises were performed as concentric and isometric contractions using elastic tubing and foam physioballs. The patients met with a trained kinesiologist who directed them in the performance of the exercises and met with the patients every 2 months to reevaluate and modify the exercises if necessary. For Group 3, the attention control group, patients attended the clinic once every 2 months. Each session lasted 20 to 30 minutes. They met with a chiropractor and completed the outcome measures and turned in their diaries, but no treatment or advice was given. What were the outcome measures? For the primary outcomes, disability and pain were measured. For disability, the Neck Pain Disability Index and the Bournemouth questionnaire were administered. For pain, a 10-centimeter visual analog scale was used. For secondary outcomes, measures included the patient's health-related quality of life, fear and avoidance phenomena measure, exercise adherence, and co-intervention information. The health-related quality of life and fear avoidance phenomena were scored with the SF-12 questionnaire and the fear avoidance behavior questionnaire. There were some obvious inconsistencies in this study that call into question the strength of the results. For example, if we look at pain for less than a year, in the attention control group, pain for less than 1 year equaled 3.7% of patients, whereas in the other two groups it was 9.3 and 9.1% respectively. The percentage of males was lower in the attention control group compared to the other two groups. After dropout, the total in each group was different. The dropout rate was higher in the attention control group with a final N of 29. For the SMT group, the final N was 36, and for the SMT plus exercise group, it was 33. Let's look at the final outcomes for Phase 1, or the symptomatic phase. The average pain level of participants decreased by 1.2 centimeters on the VAS. The disability level decreased by 4.9 points on the Neck Disability Index and decreased by 6.5 points on the Bournemouth questionnaire. For function, active range of motion increased by 6.5 degrees for rotation, 2.4 degrees for lateral flexion, but decreased by 14.1 degrees in flexion extension. So how do these differences measure against established clinical significance thresholds, or CSTs? The CST for the VAS is 1 out of 10, and in this study, the mean difference was 1.2. For the Neck Disability Index, the CST is 8 out of 100, but in the study, the mean difference was only 4.9. For the Bournemouth questionnaire, the CST is 4.4 out of 70, and the study mean difference here was 6.5. Looking a little deeper, the range of pain was quite broad. At the start of the study, the VAS range was 0 to 8.1, and alarming is the range after treatment in the first phase, which was 0 to 8.5, even though on average it decreased. The improvement in range of motion was also disappointing, given these were combinations of right and left rotation, lateral flexion, and flexion extension. The standard deviation for examiner agreement would likely wash away any of these differences. Measurements after the preventive phase of this trial indicated, in essence, no real differences among the three groups. The researchers make some attempt at explaining why a no-intervention group would fare as well as two active treatment comparison groups. One suggestion is that the use of ice was much higher in the attention control group, and that perhaps their coping methods were more effective. Although the researchers indicate that placebo may explain the success of the no-intervention group compared to the active groups, placebo is unlikely an explanation given patients realized they were not being treated, so expected no real change. Remember, they had already been treated in the symptomatic phase of the trial. There are a number of concerns regarding the strength of the findings in this study. The groups were too small for statistical power. The study required at least 35 in each treatment group. Looking at the exercise group, the exercise compliance was actually dismal at only 48.8% on average. It's unclear why the design of the exercise intervention was not evidence-based, which would then have focused more on the deep neck flexors instead of the broader approach used. It's unlikely that the effectiveness for exercise can be determined given the compliance rate was less than 50%. What the results might be indicating is that the practicality of expecting high compliance for patients with neck pain is called into question. but this says nothing about the role of exercise in the prevention of neck pain. We know the groups were not equal at baseline as discussed previously with regard to pain levels and gender. The low level of pain at the onset of a preventive phase is so low, measuring change is simply unable to detect differences among groups. Frequency of a reoccurrence would have been a better measure, but this was not included. Finding value in the results is itself a bit of a pain in the neck. So what are we to gain from the information derived from this study? Unfortunately, it confirms that chronic neck pain is difficult to treat, and certainly difficult to study. This is a very good start at what should now result in a larger study with some modifications. The modifications should include a measure of the number of recurrences, an attempt to increase the compliance rate for exercise, and to focus more on the deep neck flexors. The researchers should be congratulated on a good initial start to answering a very important question regarding chiropractic preventive care.